Hello, welcome to Holmes Community College Paramedic Program. Glad you're here. We're going to start tonight's lecture with the cardiac cycle. It's the first of a series of lectures on the American Heart Association guidelines for ACLS. This first lecture is specifically to help you understand and recall why we are correcting arrhythmias. The cardiac cycle made up of diastole and systole, and begins with diastole, the relaxed heart muscle that is refilling since the last contraction. The filling is passive. The blood returns to the right side of the heart through the superior and inferior vena cava, and to the left side of the heart from the pulmonary trunk through the pulmonary artery. The blood that moves through the atria moves through those atrioventricular open valves and fill the ventricles during this diastole. Approximately 70% of the blood that's going to be available in the ventricles for delivery during the beginning of the systolic phase is filled during this diastole passive filling cycle. After the diastole has occurred and the passive filling has occurred, the atria can finish the filling of the ventricles to provide the amount of blood that's going to be ejected during systole. When there's depolarization of the ventricles, the last amount of blood that moves from the atria into the ventricles begins with the atrial kick, the depolarization of the atria. When the atria contract, they eject approximately 30% more blood into the two ventricles. About 30 milliliters of blood is pushed with force through those AV valves into both ventricles. This is the beginning of the ventricular depolarization immediately after that atrial kick. And at that point, the ventricles contract simultaneously. The blood that leaves the right ventricle goes through the pulmonary trunk and is oxygenated, and the blood that leaves the left ventricle goes through the aorta to systemic circulation. The amount of blood that leaves that left ventricle is stroke volume. We eject about 70% or 70 milliliters from our left ventricle with each contraction on a normal working heart. That amount of blood is the stroke volume. Stroke volume times your heart rate, how many times it beats in a minute, equals cardiac output. The reason these matter is because when we correct arrhythmias, we're trying to balance out either a stroke volume that was inadequate, or we're trying to correct a rate that was not meeting the cardiac output demands of the brain and the rest of the human. So keep those numbers in mind. The atrial kick provides about 30% of the volume that's available for the ventricles to eject during the beginning of systole, which is ventricular depolarization. These matter because we start out with the preload, which is the amount of blood that is available for that ejection. We start out with that four-chambered heart. We've got the right and left atria, the right and left ventricles, and the blood that moves in through that superior and inferior vena cava into that right atrium pour into that right ventricle. The blood that moves from the pulmonary trunk into the left atrium and pour through that left ventricle during diastole, passive filling, totals up to approximately 70 milliliters. When the atria contract, the beginning of the depolarization of the atria, the amount of blood that ejects from the ventricle, from the atria down into the ventricles, is another 30 milliliters. Gives us a total of 100 milliliters on a normal working heart available for ejection during the beginning of systole. When the ventricles depolarize and contract, they eject about 70% of the amount of blood that was available. That is your preload. On a normal working heart, we're ejecting 70%. That's ejection fraction. We're ejecting 70%, which is about 70 milliliters. That is stroke volume. stroke volume times heart rate equals cardiac output. It matters because when we're going to correct a patient's inability to meet metabolic demands of the brain or other organs because of cardiac function, we can get involved in the stroke volume, we can get involved in the heart rate, we can get involved in the amount of blood that returns, the amount of volume that returns during diastole. So we've got cardiac output, we know what that is. Cardiac output times systemic vascular resistance, and I want you to recall these for every patient that you ever come in contact with, because those two combined together equals the patient's blood pressure. Now, we can measure heart rate. We can't really measure stroke volume. We're going to use these normals for that we know about humans, but we can measure blood pressure. And when we measure blood pressure and we're listening to the arterial pulse waves, when we're auscultating those cortical sounds, what we're hearing is the ejection of blood during that systolic phase. So blood pressure is a systolic over a diastolic pressure in millimeters of mercury. We also take this one step further, because when we're trying to correct arrhythmias in American Heart Association guidelines for ACLS, we're not really looking at a blood pressure. I'm not correcting a 120 over 70, or I'm not correcting a 90 over 50. I'm correcting the next step that we go after blood pressure, which is the mean arterial pressure, the MAP. And we can look at a MAP quickly and we can remember one single number, because if we already got stroke volume times heart rate equals cardiac output, and cardiac output times systemic vascular resistance equals blood pressure. Blood pressure can be further defined as a MAP, a mean arterial pressure, by taking systolic plus diastolic and dividing it by 3, and we can get the MAP. A MAP that will meet the metabolic demands of the brain should be 65 equal to or greater than 65. So if we're looking at anybody's blood pressure, we can quickly say systolic plus diastolic divided by 3. That's my mean arterial pressure. If I'm not at 65, then I probably don't have enough to meet their metabolic demands of the brain. I'm not getting enough oxygen and glucose pumped up to the brain to meet the demands of that human. So I've got my MAP, and I can take it one step further for your information. MAP minus ICP equals CPP. What's ICP? Intracranial pressure. It's usually on most humans, 10 to 15 millimeters of mercury. So 65 minus 10 or 65 minus 15 equals what a normal CPP, cerebral perfusion pressure, should be, which is 50 to 55. These are normal humans that are able to think clearly, do the functions of life, and their brain is not starving for oxygen or glucose because the pump went too slow, or the pump didn't pump hard enough, or there wasn't enough volume available. So when we're fixing something on an arrhythmia, we're thinking MAP, we're thinking mental status, we're thinking I've got to get a mean arterial pressure equal to or greater than 65, because I know a normal human's got an ICP, intracranial pressure, of 10 to 15 millimeters of mercury. The MAP has to overcome the ICP to get to cerebral perfusion pressure, 50 to 55. I hope that was clear cut.